So comorbidities and rheumatic diseases. I'll be presenting a case, then we'll go through the most common comorbidities that we see with a general overview, and then specific comorbidities, how we assess the risk and how to manage. So in 1988, a 25-year-old female presented with a malar rash, arthralgia, and hair loss. She was worked up at that time for connective tissue disease and was anti-RMP positive, anti-Smith positive, and anti-Rho positive, of course, with a positive ANA. She was diagnosed with SLE based on the clinical and serologic criteria, and this was treated at the time with low-dose steroids and hydroxychloroquine. She presented again in 1992 with a vasculitic skin rash. Her skin biopsy at that time had confirmed vasculitis, and she was again started on moderate dose of steroids for a few months, along with azathioprine, which is Imuran. Patient lost follow-up for a few years and came back with worsening in her respiratory symptoms, and further workup had confirmed that time the presence of an ILD with pulmonary hypertension. Immune suppression was restarted, and the patient again was on steroids and MMF. In 2013, patient presented with chest pain, and a diagnosis of a non-ST elevation MI was made. She had a coronary angio and stenting of her coronaries, and the patient was started, of course, on anti-ischemic antiplatelet therapy. In 2018, she came back again with acute retrosternal chest pain. Another STEMI was diagnosed. Coronary angio at this time had shown extensive triple vessel disease with coronary vasculitis, which was because of the amount and the extension of the coronary occlusion and irregularity that was seen on angio. So this was suspected. Stent placement CABG could not have been done at that stage as vasculitis was highly suspected. So there are important challenges that were faced in this case. So was her last event, was it atherosclerosis? Were we only dealing with ischemic heart disease? Was this really a vasculitis related to her lupus activity? Was it her SLE or was it the steroids that we should actually blame for what she had developed? What could have we done to prevent this earlier? Could have we treated to target earlier on? Did we not treat to target? Was she compliant to her treatment? Did we really look at her comorbidities during all these years? And how could we treat her now? So comorbidities and rheumatic diseases. A comorbidity is a condition that coexists along with the index disease, could be related to the primary disease, could be related to treatment, or be completely independent. These can influence the patient's quality of life and prognosis more than the actual primary disease. It can affect our treatment choices, and the concept of treat to target in rheumatic diseases means that our patients will live longer, and recognizing these comorbidities can affect their quality of life and prognosis. So whose responsibility is it? The care of rheumatic diseases, of course, is a focus of a rheumatologist, but our clinics are very busy. Are we really looking at comorbidities? Comorbidities are often managed suboptimally by the rheumatologist in particular, and of course the healthcare team in general, because we think that someone else is taking care of these comorbidities, and other medical professionals like general practitioners or internal medicine physicians are thinking that we are actually following these things up. So what are the common comorbidities? First, cardiovascular disease, then comes infections, malignancy, osteoporosis, insulin resistance, and interstitial lung disease. Cardiovascular disease and rheumatic diseases. Cardiovascular mortality is known to be high in patients with rheumatic diseases. RA has a twofold increased overall mortality, with cardiovascular disease being the leading cause of death in RA patients. And SLE has a bimodal peak of mortality seen in the second decade and again in the fifth decade. A meta-analysis of 24 observational studies of cardiovascular disease-related mortality in patients with RA reported a 50, 59, and 52% increased risk of cardiovascular disease, ischemic heart disease, and cerebrovascular accident deaths, respectively. Women with SLE in age group of 35 to 44 are over 50 times more likely to have a myocardial infarction compared to age and sex matched controls. SLE patients also have a twofold to tenfold increase in risk of stroke. And accelerated atherosclerosis has also been noted in other rheumatic diseases like vasculitis, psoriatic arthritis, ankylosing spondylitis, and scleroderma. And a high proportion of RA patients are reported to have heart failure with preserved ejection fraction. So, pathophysiology. Atherosclerosis is known to have a central role in pathophysiology of cardiovascular disease in rheumatic diseases, and accelerated atherosclerosis and vessel inflammation in the form of vasculitis could also have a role in cardiac ischemia. Risk factors for cardiovascular disease. RA is independently associated with increased cardiovascular disease after adjusting for traditional cardiovascular risk factors. Systemic and vascular inflammation related to disease activity. So when your disease is active, you're more likely to develop atherosclerosis. Smoking, of course, especially in seropositive patients. Hypertension and SLE, and abnormal lipid profile, especially in patients with RA, those that have psoriasis and psoriatic arthritis and ankylosing spondylitis. Increased insulin resistance, again in RA and lupus. And low body mass index has been reported to have a paradoxical effect on survival in RA. And of course, obesity, which increases the cardiovascular risk. Most NSAIDs and COX-2 inhibitors have been associated again with increased cardiovascular risk. Corticosteroid use, especially if we use higher doses for longer durations, a dose of more than 7.5 milligrams for longer than 3 months carries this, again, increased cardiovascular risk. And of course, hypertension. And hypertension could be a primary comorbidity or could be secondary to drugs we use, like leflunomide and cyclosporin. So how do we assess this cardiovascular risk? Disease activity, of course, and severity have been found to correlate with cardiovascular events, so we have to know how active our patients are. Having higher ESR and CRP have been found to correlate with increased cardiovascular disease. The ACC and AHA tool for cardiovascular risk assessment helps us in quantifying this risk. And again, there's the Framingham risk score, which can also be used. There is the 2008 version that can predict the 1-year global risk of cardiovascular disease and specific cardiovascular disease endpoints, and cardiovascular risk management guidelines from the EULAR task force actually advise us to use the SCORE algorithm, which is from the European Cardiovascular Society, which again tells us that we can estimate cardiovascular risk, and for those that have inflammatory joint disease, we should actually multiply that risk by 1.5. An easier tool risk that we can use is the QRisk 3, which has been developed in the UK. And this is an online tool. You just log into the website. You can fill in all the details, which only takes a few minutes, and it can actually predict the cardiovascular risk for your patients. And patients can even can use this tool themselves. So EULAR evidence-based recommendations for cardiovascular risk management in patients with RA and other forms of inflammatory arthritis recommend that patients should be screened for cardiovascular disease and traditional cardiovascular risk factors routinely. And we usually do that during each visit. We measure blood pressure, we ask patients if they have chest pain, if they have respiratory symptoms, which can sometimes be equivalent to chest pain. So having shortness of breath can be angina equivalent. And we run our blood tests like lipid profiles, hemoglobin A1C, biannually. And appropriate management of metabolic syndrome, smoking cessation, of course, we always ask them if they smoke, if they have stopped, we give advice. And all of these, along with the minimization of corticosteroid use and the cautious use of NSAIDs, help in reducing the cardiovascular risk. So cardiovascular risk management, there are two main principles: tight control of disease activity, which is the responsibility of the rheumatologist, and minimizing traditional cardiovascular risk factor, which is responsibility of a rheumatologist and other healthcare professionals. So treat to target and effective use of DMARDs in inflammatory arthritis has been shown to be independently associated with a lower cardiovascular risk. And making changes to lifestyle, like smoking cessation, eating a healthy diet, getting enough exercise, becoming a healthy weight, reducing drinking for those that consume alcohol, drug treatments to lower cholesterol. Hydroxychloroquine, which is a medication that we commonly use, known as Plaquenil, has been shown to have pleiotropic beneficial effects. It has antithrombotic effects, lipid-lowering effects, of favorable glycemic properties, and may reduce incident cardiovascular events in RA patients. So the second comorbidity that we commonly come across is infection. So infections and rheumatic diseases are a major cause of morbidity and mortality. An increased risk of infection is related to disease activity and, again, the use of immunosuppressive treatment. It may be difficult to identify, especially that our patients, most of them are on immunosuppressive treatment, most of them are older, so they may not manifest all the like fever or the rise in inflammatory markers earlier on. And early treatment is very important. So we have to recognize these features. Risk factors for increased risk of infections in RA include advanced age, being a male, a patient, increased disease severity, smoking history, having leukopenia, whether primary or drug-induced, presence of extra-articular manifestations of RA, like having an ILD, and the presence of other comorbid conditions, such as having diabetes or chronic lung disease, being an alcoholic, or having dementia. So patients with SLE have a greater risk of infection that is related to significant morbidity and mortality, and along with active lupus, infections were the most common cause of death. Disease duration, disease activity, again, leukopenia, having nephritis, hypocomplementemia, concomitant use of steroids, especially if they're higher dose, longer duration of time, and along with with the use of heavier immunosuppressive treatment like cyclophosphamide have all been linked to increased risk of infections and death. The risk of infection with DMARD is the least with methotrexate. So among all our conventional DMARDs, we say that methotrexate has the least risk, but of course we have to make sure that our patients don't develop leukopenia. And the risk of infection is increased by 20% for patients on anti-TNF therapy. And the same applies for most of the biologic therapy that we use. So common rheumatic diseases-related infections, there are the serious and opportunistic infections, especially with the use of high-dose steroids and biologic therapy or cyclophosphamide. Chest infections are commonly seen in RA and SLE patients. Skin infections, TB reactivation, which I have to be aware of, UTI, and hepatitis B reactivation, which patients are usually screened for. So the key recommendations for clinical practice is we screen our patients for TB, especially prior to starting biologic therapy. We screen for HBV infections prior to use of other immunosuppressives. So we screen for hepatitis usually B and C. We vaccinate our patients with inactivated vaccines, and we make sure that they're annually vaccinated with vaccines like the flu vaccine. We use steroids cautiously, and we always must review how much the patients are taking, for how long they've been taking steroids, and the early, of course, and judicious use of antibiotics. The third common comorbidity that we see is malignancy. So increased risk of malignancy has been reported in different rheumatic diseases, and there's of course the role of genetics, viral infections, and smoking. Disease activity and the chronic activation of B and T cells is the driving force for development of cancer and rheumatic diseases, especially in diseases like Sjogren's disease or lupus. And the effect of immune suppression on increasing the risk of malignancies is always there. So it's the disease itself that can be the driving force when it's active, and again, our use of immunosuppressive treatment. So SLE is associated with increased risk of different malignancies, increased risk for hematologic malignancies, especially non-Hodgkin's lymphoma, myelodysplastic syndromes, and acute myeloid leukemias. And observational studies in lupus suggest increased risk of cancer of the vulva, lung, thyroid, and possibly liver, whereas decreased risk for breast and endometrial and possibly ovarian cancer. And patients with lupus that were HBV positive were found to be at high risk for anal cancer, vaginal vulvar cancer, epithelial dysplasia, and carcinoma in situ of the uterine cervix, and non-melanoma skin cancer. And here comes the importance of having our patients vaccinated early, especially that the vaccine has been recently introduced in MOH. And these are the different autoimmune diseases and different malignancies that we come across in these patients that I just spoke about. So, DMARDs and malignancy. Can our medications cause cancer? The increased risk of malignancy in patients with rheumatic diseases and the intensive use of DMARDs in patients with advanced disease who might already have a higher risk of developing cancer made this assessment challenging. So, is it the disease? Is it the treatment? An increased risk of malignancies, of course, is well known with drugs like cyclophosphamide, especially uroepithelial cancers like bladder cancer. And a higher risk of lymphoma was also suggested in lupus patients treated again with cyclophosphamide, especially for those that have or take a higher cumulative dose of steroids. An increased incidence of cervical intraepithelial neoplasia in women with lupus treated with intravenous cyclophosphamide and steroids was also again reported. So increased risk of malignancy with azathioprine has been well established. So we try to use these medications for the shortest period of time and as long as we use them. And as long as the patients are on these medications, we always advise them to screen. We always tend to fully examine them when they are in clinic and ask them if they had developed any new symptoms not related to their disease. An increased risk of malignancy with methotrexate. Now, this is kind of questionable. Methotrexate is our anchor medication actually in rheumatology, and there were initially studies saying that there is an increase of malignancy with methotrexate, but this is not firmly established. And no association was seen with the use of anti-TNF therapy except for melanoma and non-melanoma skin cancers. And of course, now we have the JAK inhibitors. Again, there were black box warnings, and there are still ongoing studies to establish the risk of malignancy with the use of these medications. So key recommendations in clinical practice, it's simply routine screening. So do what you do for your general population. Examine your patients. Always make sure that they've done their mammograms, ask them about family history, make sure that they've done their colonoscopies, they've done their pap smears. So rheumatic diseases and osteoporosis, this is a very common thing that we see in clinics. So increased risk of osteoporosis in patients with RA has been reported in many studies. And of course, we use steroids, so avoid using steroids for maintenance of treatment, especially that we have so many treatment options now in the form of DMARDs to control our diseases. And making sure to maintain vitamin D levels, balanced diet, exercise, and most importantly, again and again, smoking cessation. And we can use FRAX tools, and we can use DEXA scans to make sure that our patients don't have osteoporosis. Insulin resistance. The association between RA and insulin resistance has been established in many studies, and cumulative glucocorticoid dose was shown to have a negative impact on glucose tolerance state. Data from different studies suggest favorable changes in measures of insulin sensitivity with the use of traditional DMARDs such as methotrexate and hydroxychloroquine. So again, we have to control our disease earlier on to avoid developing insulin resistance. So what did we learn today? Our shared goals should be raising awareness regarding comorbidities among providers and patients. So patients should be aware, we should be aware, other healthcare professionals should be aware. Regular screening, always and always screen your patients, make time for it. Tight control of rheumatic disease activity, which is the general concept that we apply in all rheumatic diseases now. It's treat to target. Interfere early. Bear in mind the risk and benefit of treatment choices. So whenever you prescribe a medication, you should explain to your patient what the risk is, what the benefit is, how to weigh both, and what to expect in the future. So close collaboration between multiple disciplines, including the rheumatologists, primary care physicians, other specialties, could optimize effective management of comorbidities. Thank you.